Dr. Joseph G. Jemsek, known to many of his patients as Dr. J, is the namesake and founder of the Jemsek Specialty Clinic in Washington, D.C. In 1983, while working in the state of North Carolina, Dr. Jemsek diagnosed the first case of HIV/AIDS in that state. He dedicated the next 2 decades of his career to the care of those severely ill and marginalized patients. In 2001, he began to see patients suffering from what would later be termed Lyme borreliosis complex, LBC. Dr. Jemsek became increasingly intrigued by LPC's complexities, which led to his interest towards understanding and treating these often marginalized patients. As an infectious disease specialist, Dr. Jemsek has had the distinction of being a key player in the twin epidemics of modern times, that is HIV/AIDS and Lyme borreliosis. Oh, I can't say it. I got stuck. Borreliosis. Over to you, Dr. Jemsek. I will share your slides when you ask me to start. But I will mute myself, turn my video off while you're talking. Just if you want me to come back at anything at all, just shout and I'll be there, okay? So do you want to say a few words before I start sharing your?
Yes, please.
Okay.
I just want to thank everyone for the opportunity and really look forward to sharing with you something that was born 2 years ago when I was invited to do a presentation in central London at Holiday Inn, which was very well attended. I brought my 2 teenage children with me, and Natasha and Anne and many others put a lot of work into it. And I even examined our moderator on stage, Julia, and the one word that she kept saying over and over was "ouch." So she was a good sport, no doubt. But prior to my arriving, we'd had the idea of, wouldn't it be nice to have a booklet that promoted self-help to the 95+% of folks who can't access quality medical care for a number of reasons, any number of reasons. And so Anne Gregson did some wonderful writing and organizing the pictures and so forth. And I was amazed to see what we had. I think we had a couple 100 pamphlets, and that's what we're going to talk about today. It's been tweaked a little bit. It's going to continue to be tweaked. But I don't think that there's anything more important than we can do is to reach out to the disenfranchised who are suffering, and to, in very simple terms, or relatively simple terms, explain to them things that they can do to improve their quality of life. And in essence, if you boil it down, we're talking about reducing an inflammatory quotient that this disease is renowned to do in the body. In other words, chronic inflammation is 24/7. With Lyme borreliosis, it's like dying with cancer, except you don't die. And so many are suffering, so many cannot access care, so much denial by the government for care and lack of recognition. And I know some things I've written 10 years ago, 15 years ago, or said, I've seen no change. It's so frustrating. But we keep trying. And that's what we're going to talk about tonight. And then we'll have a list of questions afterwards that aren't necessarily related, but of interest. And we can go from there. So if you would put up the first slide, Julia.
I will do. I'm just going to share the screen. Before I do that, I just want to mention that when I said that everybody will get a recording who's registered for the event, they will also get a PDF of the booklet you've just mentioned. So I'm just going to share your screen now. Okay, so I'm just going to turn my camera off.
Well, if you see the mantra at the very bottom, it says "Choose life over Lyme." And I'm going to talk later on about shower thoughts. And that literally came to me during a shower, that mantra. So we'll talk a little bit more about shower thoughts. Next slide, please. Yeah, so if you look at the third paragraph, the goal of the document is to reduce inflammatory quotient through self-help. If the patient or the sufferer in question has some help or can do some things on their own, they can improve the quality of life. And this is a good time to mention that there were collaborators. I'm getting way too much credit for this. I've already mentioned LDUK and Natasha and Anne, but also we had co-authors, Dr. Dermot O'Flynn, who has an interest in intermittent fasting, and Andrea Caesar, who wrote Twist of Lyme. And she did a page on meditation, among other things. Next, please. So we have three broad ways to reduce inflammation in our body, and dietary choices are one of them. Supplements are another, and sweating is a third. And then there are all sorts of nuances off of that. But the gluten-free diet is number one. And there's even some controversy today about, well, it's not a real thing. You know, people don't have gluten intolerance. They don't promote an inflammatory response. And I think that's nonsense. I think some are much worse than others. And everything in this disease with chronic inflammation is sort of laid bare. And people are exposed if they have certain genetic patterns, you understand. So that's why there's such a smorgasbord of symptoms and intensity of various symptoms in different people. So when we talk about moderation in some of the foods, I'm skipping down a little bit. Don't overread that. This can just be a moderate reduction if you're overproducing tyrosine or something like that. You can't eliminate. You have to be practical about it. Same thing with histamine containing foods. Just don't eat them 3 times a day. So let's be practical. But the gluten is number one. There are other food groups that I'll briefly mention that affect some of the population. I don't automatically withhold dairy because I'd like to know whether or not the patient actually has difficulty with dairy before we say you can't have dairy. That cuts out a huge swath of nutritious foods. Next, please. Intermittent fasting. There's a lot written on this. This came to the fore in 2012. It can be done in different ways. You can fast or not have any food product for 16 hours and then eat a moderate amount later in the day. You can do that 5 days out of 7. You can do a liquid-only diet for 2 or 3 days. And what happens is you detoxify. The ketones that are formed are actually preferred by the brain for energy. So there's no lack of energy. They're also function as antioxidants. And I've had patient after patient tell me how clear their minds are if they're able to do this. So if you're a patient at home with no access to medical care and you can do this, and then I think you're going to benefit. So it's a good tool to rev up or boot up the ketosis system. And after all, this is evolutionary, right? So our ancestors didn't eat 3 meals a day. So it's an evolutionary process. So of course you burn fat, but this is not all about losing weight. It's about reducing the inflammatory load, and in the process, doing some very nice things to brain clarity. Other antioxidants are curcumin. Curcumin is my favorite. It's a little bit bitter. Dose would be 500 milligrams a day. And then green tea, I think, is especially matcha tea, is the prime antioxidant on the planet. But curcumin's had more articles written about it than just about any other supplement. Resveratrol is also very good. but it has a phytoestrogen effect. And so I'm hesitant to give it to ladies who have anybody in the family or who have a personal history of estrogen sensitive receptor cancer. So they don't get it, even though it's a mild phytoestrogen, I just don't give it. Omega-3 or krill oil, it's last time I checked, it was neck and neck. I really don't care. It's a very nice anti-inflammatory, and sometimes I'll use it if premenstrual women are having an awful time with a spiking of symptoms for anywhere from 2 to 5 days before they menstruate. It can be very helpful. Herbapinella, everyone is aware of. We found some herbs that help people, and they became quite popular. And you may know that they're now combined as one product in under some manufacturers. Next. So the third leg on the chair is sweating. And again, there's been a lot of pushback on this. When you say you sweat and there's no evidence that you're excreting any toxins. Well, that's nonsense. I mean, at some time or other in our lives, we've done a good sweat and a good run, a good workout, tennis game, hiking, or even a sauna, and sweat and then feel better, right? Now, our population doesn't feel better because their oxidative stress curve is already tilted to the left. So when you are dealing with this illness and you find that you can do some sweating, and when you feel better for it, then you're started to make a recovery. That's a key sign that you're coming back. Otherwise, as many of you know, people that try to exercise in the midst of the illness with all the inflammation going on will crash and burn. Epsom salt bath is a passive way, again, to sweat. And I prefer the more active way, but not everyone can do it. Not everyone can do the Epsom salt bath. So let's do an Epsom salt foot bath and start with that. Stretching and toning is very important. We need to activate our muscles every day and get the lymphatics going. That's a nice thing to do before you get in a sauna or before you get in a salt bath to get things activated. The reason why some people can't do massages, for example, is that there's just so much toxin laden in the tissues, and so they don't benefit from it at all. They don't like it at all. One little trick for either an Epsom salt bath or a sauna, or even a mild workout, would be to drink some hot green tea. Don't burn your mouth, but hot green tea, get the internal core temperature built up. And you'll find that the threshold for sweating is reduced, and it'll be more efficient, and you won't have to spend as much time in the tub or sauna or even working out. And when you do work out, let's do dynamic workouts, and we're going to do one thing for a few minutes and then another thing. Last thing you want to do is over fatigue the muscles with all the lactic acid coming out and make that workout a negative experience. Next slide, please. This is on our website. We have a number of innovations that we've done over the years. I think it's about 25 now. We've probably got some more. One of the first things I did early on was to say, I have to organize this disease. And it's got so many moving parts. What do we need to stabilize our patients? So I came up with POEMS, an acronym. P stands for pain. And this all has to do, for the most part, with physical, biochemical, social, endocrinologic, psychiatric, and sleep support. So essential life functions include, we have to have our hormones, we have to sleep, we can't be off the reservation in terms of our mood and can't be managed, and we can't have intractable pain that is trapping us. And guess what? Quite a few of our patients have all these things going on. So I think everyone knows our paradigm by now, that we spend anywhere from 2 to 6 weeks or as much time as necessary to stabilize the patient, and we'll tell them if we're not able to do it. There are different types of pain. I won't get into that, but they require different approaches. And we don't try to eliminate all pain. We simply try to get it to a manageable state so that the patient doesn't feel tortured. And so we can do a moderate therapy without, and which may involve some herxing, without putting them down in the bed. Other talks about mostly clinical support, social support, and it could be another co-condition not related to Lyme that needs to be managed. But we can't treat anyone successfully who doesn't have a strong support person who knows what's going on every day. It just won't happen. And that person has to believe in them. And sometimes they don't believe in, obviously, unfortunately, but they have to be there. And that can be a church member, it can be a neighbor, it could be a cousin, it could be immediate family. But we need a dedicated person. It's a lot to ask them to do, but it's necessary. Endocrine disorders are all over the place. The main one that can put the axle in the mud is adrenal insufficiency. So that's one that we really look at carefully. We do a lot of salivary cortisol tests if we're not certain. And we need to understand that sometimes the endocrine system flips. So they're non-24 circadian. So they've flipped their endocrine system or adrenal system so that their adrenal starts working at 12 o'clock at night. I'm sure everybody knows somebody like that at 11 or 12 at night, I'm starting to get some energy. I need to do some things. So that's what's going on with that. We need to be aware of that. Mood. Everybody, I have a mood condo concept that I'll spare you. But let me just say the first floor is frustration and irritability. And when I say that to a couple, that one couple looks at the other and smiles because everybody's irritable because they can't control many things in their life and they can't function in anywhere near a normal way. So everybody's irritable and then it goes up and can be much worse. Sleep is becoming a major science and the importance of deep sleep and REM sleep is emphasized. There are smartwatches now which cost money but are pretty effective, made by several companies, including Fitbit, Garmin, and of course, Microsoft and others. So, but we will discuss with the patient all aspects of sleep. We'll spend 15 minutes talking about your sleep patterns and what wakes you up and why it wakes you up. And it could be anything from night terrors, which we'll talk about, to diabetes insipidus, and which is not listed here, but which has people going to the bathroom with full bladder 3 times a night, disrupting sleep, restless legs, sleep apnea, parasomnia, even seizures or movement disorders. So we're happy to work with sleep physicians, but we're usually able to improve the situation adequately on our own. And there are only a handful of medications that really promote deep sleep. And I think the drug over there is Zolpium that everyone's taking or been given. That drug is not very good for deep sleep, just so you know. Let's go ahead and move on. Body and mind dynamics. So this is resetting the brain, and this is what Andrea does with her center in the Northeast, and what Julesy Capon does here in the DC area and does so very well. We've done 13 live streams, and Julesy's co-hosted with about 6 or 7. And, you know, we've talked about this subject to some degree. We had Dr. Bransfield on last week, and we had, you know, thousands of views. The idea is to shift the brain away from being distracted to really go from the executive function, which can be overwhelming, to another part of the brain called the prefrontal cortex, which is quiet, isn't startled and is more creative. And so any way you can do that, whether it's a light massage that puts your mind at rest, whether it's meditation, whether it's the grounding, which Andrea has discussed with me, where folks just are asked to take deep breaths, nose to mouth, 3 or 4, and then use each of their senses to perform an action, and then think about what they've done, and then take more deep breaths. In doing so, you're giving your poor brain a break. You're letting the tormented brain is allowed to have a reprieve, which hopefully lasts more than 10 or 15 minutes. The same thing happens in a shower. When I discovered shower thoughts a few years ago, I thought we ought to have a shower pad so you can write things down. And I was reading about it the other day, and somebody's already invented the darn thing. So there you go. A few years late. But these are things that anybody can do, anybody that's able to be upright and can tolerate a warmer bath or shower. And I think the mental aspect of getting free, and it induces endorphins, it induces dopamine, and just gets you away from that frantic executive functioning, which you're not doing very well anyway, and relieve the tormented brain. It can be done on a regular basis, 2 or 3 times a day, to give that person some relief. Next slide, please. Leaky gut, another controversial subject. Our patients have dysbiosis, which means dysregulation of the normal gut hierarchy. When we were born, we were colonized with mother's milk and so forth, with good basic bacteria from the lamina propria in the small intestine. Since the stealth pathogens enjoy infecting all tissues, including the gut, they completely alter the landscape, and things that we introduce in our mouth, which are not pleasant to think about, quite honestly, because we swallow dirt and all sorts of things inapparently. And it just happens. At any rate, over time, because of an unhealthy gut situation, we have unhealthy gut flora, and that leads to SIBO, or too much urea. And it also leads to the gut dissipating and splitting. So the lamina propria are not adhesed. It's a one-cell system. And behind the lamina propria is a very rich immune system, which ordinarily behaves itself and does routine functions. But in the presence of gluten, especially for whatever reason, teleologically, we don't do well. And so that's why gluten is number one. And that's why there's so many diet books and health books, and FODMAP, and vegan, and all kinds of things that tell you not necessarily about weight, but just about health. We like well, I'll get to the smoothie, and we can talk about that then. Next slide. Oh wait, we are in the smoothie. Go back, please. All right, so the smoothie here is incorrect. So this is for a week, folks. So it's a liter of not rice kefir, maybe goat kefir, but milk kefir if you can handle it. And some of the flavored stuff is okay. There's just not not that many calories. This is not about nutrition, but it is about antioxidant properties, and it is about providing the gut with superfoods. Coconut milk is replete with about 60% of coconut milk or product is good healthy fat composed of lauric acid, caprylic acid, capric acid. They're all wonderful. They promote adhesion, at least lauric acid does. You can buy monolaurin over the counter. You can buy MCT separately, or you can just make a smoothie like this. To the smoothie, you add your protein source, which is glutamine powder or whey. Some people can't handle glutamine because it's in constant conversion with glutamate. And if the glutamate is plays mischief with oversensitized brain, your brain's going to be so distracted that you'll just be not able to function. But most people can take the glutamine. If not, then pea protein or whey protein possibly. Next, the matcha green tea, which is the antioxidant king of the planet, 8 teaspoons. Now you've got your mix. You can add, I want you to add some coconut oil too, because it's 100% fat. So the coconut oil is 3 tablespoons. And I said the coconut milk was 60% fat, it's 20% fat. So you drink 4 to 6 ounces twice a day, and you can customize it each week by adding either berries or greens, cocoa powder, avocado, organic peanut butter. Trust me, you can make it taste good. And this gets back to whether or not your gut can handle fermented foods. And I think we're going to talk about that in a moment. Next, please. Mental hygiene. This one is a busy slide, and it's really not ideal for self-help. But if you take the, but actually, we can make some conclusions. So if you're having certain symptoms, such as being serotonin sensitive with all sorts of erratic seizures, seizures, jerking, and you happen to be on a SSRI, then you know that you're overly sensitive, and there are plenty of genetic pathways which predispose people to that. That's why it's good, if you can, to get a 23andMe analysis read by a qualified reviewer. Norepinephrine is synthesized from dopamine. This is relevant because some people, not many, but some wake up at night in terror and or they have nightmares. And this is due to an inappropriate discharge of adrenaline or norepinephrine, and puts us in the middle of the night in a fight or flight mode, and disrupts the sleep. And this may happen several times throughout the day. If you can't get a prescription or can't for a benzodiazepine that you're comfortable taking, or your doctor's comfortable prescribing, or you can't get a CBD product to inhibit that, then there are things over the counter that might help, including theanine or theanine and GABA, which is very, very light benzo, and that's why it's over the counter. Next, and is glutamate. Glutamate can be excitatory, but it doesn't provide the terror. It just has the so-called busy brain, where things are looping and can't settle down. And but fortunately, there are a couple of amino acids that are natural that may block that. One is taurine, 500 milligrams once or twice a day, depending on body size, and or theanine, 500 milligrams once or twice a day. So when we talk to our patients, we try to decide, okay, what's exciting their brain? These are all excitatory amines, and none of them are our enemy. They're just out of focus, and they're working in a very sensitized landscape, which is the brain, especially the limbic brain. Next slide. So I'll skip down to oxalates, because this is a category that we just recognized a couple of years ago. There are a group of people sensitive to oxalates, which is in our food. It's not synthetically produced in our body, but it tends to bind very avidly to divalent cations, and it tends to lodge in various tissues and be very inflammatory. So if you're at your wit's end and you've eliminated gluten, as you should, and you found that you can't have dairy products, for example, or soy products, and you've done all that and you're still having trouble after meals, then you should look at the oxalate panel to see whether or not elimination of these products would help you. And unfortunately, they're in a lot of good foods, such as spinach. A little bit tough to diagnose this. It's done by urinary testing, and it's not, that testing is not the best that we have. So if you do it empirically, though, then I just need to avoid oxalates. And last, controlling histamine. Histamine is the darling of our time, the last 2 or 3 years. MCAS is, become a buzzword. And MCAS is rare, folks. Histamine is just the bellwether for a pandemic of Lyme borreliosis. It's a pro-inflammatory cytokine that we can see. We can't see IL-6, we can't see TNF or IL-1 or IL-17, which are highly pro-inflammatory. We can't see them, but we see somebody that's flushing and blushing and having hives. And moreover, we can control it. We know something about it, and we rarely easily can control this in most people. Some people really hard. So the class 1 group would include Zyrtec, Allegra. I don't like Claritin because there was a study a few years ago in which Claritin destroyed the spirochete and caused the herx, and we don't want that. So that's your class 1, and class 2 are the old traditional antacids. Ranitidine's been pulled from the list. It was contaminated, but you have Tagamet and Pepsid. There is another natural product called diamine oxidase, DAO, which is made by Umbrellex, which I highly recommend. It is porcine derived, so if you have high sensitivity to porcine, you might be out of luck. What it does is breaks down histamine very efficiently, so it would be one before meals twice a day. That's kind of our phase 1 program. Phase 2 is we can get into blocking leukotrienes and mast cells themselves with cromolyn and with ketotifen. And there are many different forms of cromolyn sodium, which can be used. Also, quercetin is helpful as necessary, and actually doxycycline in minor doses can provide a lot of antihistamine effects. In fact, some of the sleep meds and psychotropics that provide antihistamine effect, they do multiple things and hit multiple subsets of receptors, whether it's serotonin or dopamine and so forth. So that's why sometimes it's so hard to know what the reaction is going to be, because genetics are different in everyone. So this is our first effort. It's our first tweak. I know it can be better, and would love any suggestions that you may have about things that you'd like to hear about that are applicable to patients who are trapped in their own home or trapped in their own neighborhood and have no access to care, or even if they can afford for care, they can't find someone that will help them, and who won't just put them on an endless trail of antibiotics without any real plan. So we'd love to hear suggestions on easy things to do. And I want to thank my colleagues, Julia and Natasha and Ann, and many others. And then, of course, Dr. O'Flynn and Andrea Caesar. So we can move on now to Q&A, I believe, unless we have another slide. I don't think we do. I think we finished, Julia.
Okay. Just hang on a minute. I'll come back to you. There you go. And my video should be back on, yeah? Yeah, it is. Thank you ever so much for that. That was really interesting. And as I said before Dr. Jemsek started his presentation, that everybody will get a copy of the PDF of that brochure with their recording when the recording's ready to be sent out. So that's brilliant. So thanks a lot for that. We've had some questions submitted to us prior to the event. Whether we'll get through them all or not, but we'll give it a go, and we might be able to squeeze a couple in from the chat box. I didn't say at the beginning, but there are 3 members of the team working as moderators, and if you have any problems technologically, electronically, or something's wrong, just pop a message in the chat box and they'll do their best to rectify it. Okay, so we've got a list of questions here. I think one that lots of people would like to ask is, are you able to share any further information about your big research project with the Global Lyme Alliance? Sorry.
Well, we got off to a good start, but unfortunately last February, it was terminated due to inordinate expenses, which weren't allotted due to COVID and the scarcity of people to do the study and go certain distances to obtain specimens. And even to some extent for patients to return to JSC here in DC. Mm-hmm. So with great regret, it was discontinued. It's a shame because it was going to be the first pilot study in clinical medicine using and in collaboration with 3 universities here in the United States, who all had special skills in looking at intracellular molecules and molecules of reflecting inflammation, so that we might get some information. I did speak with the acting CEO and with the acting medical director, Tim Salata. They called me and wanted to talk with me and just said, hey, we just want to keep in the loop with you. And, it's been a very bad year and we're still interested in working with you, but it may be another year. So that's good and bad news, isn't it? So we'll see. But we can certainly do this project. And I don't know, God just turned the world on its head with COVID. Of course, so has Lyme borreliosis and the struggles that this disenfranchised, very, very large group around the world has experienced.
I guess COVID's impacted so many things that's really not a great surprise, although it's sad. But hopefully, like you say, in another year or so, when hopefully we'll be back to some sort of normality, be great, wouldn't it?
Yep.
Okay, so we'll move on. I'm sort of going to mix the questions up a bit. So, do you have any extra advice on how to manage a Herxheimer reaction? In what circumstance do you think it's better to back off a bit from your protocol, antibiotics and things? If you're really suffering, is it good to back off, or do you go through?
Well, no, we don't like our patients to suffer excessively to the point that they're in great distress or alarm. That doesn't help the immune system go forward, but we know we have to experience some reactivity if our treatment's felt to be successful. We take advantage of the lifestyle of the organisms and target them in such a way that it's pulse therapy, and that takes advantage of the die-off and the toxins and the dead cells that come. We also have numerous ways to help our patients detoxify. But to your point, if it becomes too rough, we back off. We tell our patients, hey, you're going to do several cycles and they have to be manageable. And now some people are what we call minimalist, where they're tough. And I can usually find them because I know where to poke. And they say, so we get the wince sign. And, oh yeah, that does hurt. Well, it hurts a lot. So we need to know, so every patient's different. We get very few hypochondriacs or people who are, gimpy or wimpy, but you have to know your patient and how much suffering they're having. If they are having too much, we'll cut the program, we'll space the program, we'll readjust the program.
That sounds really good advice to me. Okay, what have we got here? This one that comes up quite a bit, on the support group that we run. So my mental health is now more of a problem than my physical symptoms. I'm suffering from chronic anxiety and depression. I'm on antidepressants and also taking herbs for anxiety, but nothing touches it. Is there any advice you could give somebody who feels like that?
Well, without knowing the timeline and the specific meds used, it sounds as if this person has access to medical care, and that mental health, I can just make the general comment first, that even in our treated folks, you have to understand that there's a lot of damage done and a lot of repair to be done. Once we purge these infections over a 10 to 12 month period, doing pulse therapy several days a month and doing sequencing and therapy, once that happens, we still have a badly damaged landscape. And a lot of that's in the subcortical area, where the mood exists primarily. And so our patients need to continue on with detoxing, because a toxin level, so the variation day to day and week to week can be thought of as where the toxin level is. It's kind of like where the water table is or where the creek is rising or so forth. If it's very high because you had spaghetti and a fight and with your spouse and slept 3 hours, then you're going to have a bad day because you're going to flood those susceptible areas with toxins. On the other hand, if things go in an opposite way, you'll have a better day. But besides the obvious looking at the medications being used to support, you'd ask, okay, how's the patient sleeping? That's so important. What's going on with the family relationships? Because they can fool you. And you just need to know more about the person. But mental health can come back. The mood can improve, but things have to work together. If you take advantage of some of the over-the-counter products that we've talked about, whether it's Benadryl for sleep or promethazine for sleep, maybe some prescriptions for deeper sleep, and maybe doing a little activation of the muscle, and trying to reduce the inflammatory quotient as much as possible, because even though the brain is very susceptible and damaged, doing that will give you the best sense of yourself and best outlook.
Okay, thank you. So I suppose this is another big question that everybody's been talking about. So how would you say that COVID-19 is affecting those with Lyme disease, and what are the parallels between long COVID, the COVID long haulers, and sufferers of chronic Lyme disease? Is there a parallel?
I think so. That's because I've thought about this disease in a different way for a long time, and I know that many listening understand this. This Lyme disease complex is not a one bite, one disease thing. There's accumulation of infections that are below the immunologic line, if you will, which that line is fairly thin, because the combination of these organisms appears to be relatively new, at least in such a context. My view, when we listen to our patients, when they start to edge into unwellness, it can be over 2 decades or 3 decades. They can be successful, but then you talk with them, they've suffered, and they've had periods where they've had to slow down, or they've had, mood issues or cognitive issues nobody understood, but then they get back to work and they're compensating in different ways. By finding out for themselves, well, let's not do gluten, let's sleep an extra hour, let's do a little bit of exercise, let's cut out sugar in our diet. And that can put the needle back almost to neutral, but until it can't. And so so we look at triggers, and triggers are not necessarily in your face. They can be a sequence of unfortunate family events and stressors, losing your job, losing the family's money, bad relationship with an important person, loss of someone, a loved one. It doesn't have to be an infectious event. It can be, and it can be COVID, because COVID, if nothing else, is a stressor or tipping point. And if you have somebody that's partially compensated and getting along and living their life, and as we go through this, we sort of adapt, right? That's what humans do. You say, "Oh, I've got aches and pains. Well, I'm just getting old." Well, you tell that 35-year-old, "No, you're not old, dude. You've got some issues somewhere." But people don't want to feel like they're sick, and so things edge up on them, and it may take rather severe series of circumstances like onset of seizures or early dementia. Somebody was high performing, tremors, and things of that sort to really say, okay, something's wrong. By then they've been to a dozen doctors, and then they're deep into the infection and there's no hope of getting out without help. COVID is a massive trigger. And what it does is allows the spirochete and others to burst through the immune line, and now they become opportunistic infections. And in fact, I think of this disease in a lot of ways as opportunistic infections. So, same thing for a tick bite. Let's say that you have somebody that's tottering, been experiencing good health for quite a time, and then they get a bunch of tick bites. Well, they've been slugged with spirochete after Borrelia after Borrelia after Borrelia, or ehrlichiosis or anaplasmosis or something else, more nonspecific. Anyway, the immune system is shaken and deregulates, destabilizes, and here they come. And so you can wobble down the hill, or you can stair step down the hill, or you can fall off the cliff. And COVID has thrown a lot of people over the cliff, in my view.
Yeah, definitely. Okay, this one. After a patient has undergone extensive treatment and is no longer on antibiotics, what signs would you suggest that they look for that they were having a relapse in symptoms? What are the key things to be aware of?
So I can't speak really to other programs, but except to make a general comment that presumably they've learned a low inflammatory lifestyle and they're following it. They may see that if they deviate from a gluten-free diet that they suffer for it, so they continue to avoid it. Same thing for alcohol. A lot of folks treated in any manner of ways can realize that I'm not sleeping as well, I'm starting to get sick again. In our program, we do step downs, and we don't stop antimicrobials. We cut them back dramatically, but we don't stop them. We like to watch them do a maintenance interval, which I think tweaks the immune system, and my idea is it slowly raises the immunologic barrier advantage, if you will. And also, the T cells are a lot smarter. The memory cells are a lot smarter now. Before they were not only weak, but they were dumb. And by virtue of a good patient compliance with lifestyle and adjustments that we're able to make, or other people able to make, treatment, they come out and they have blue sky days. And we see patterns like that time after time, and that's what we're looking for. We know how much time it will take. Now, if somebody's in a first year of maintenance, dosing 3 days, 4 days a month in 1 week, meaning that they have 23 days off, if they start to have more reactivity on the maintenance week, that's not a good sign, especially if the trend has been otherwise. If they can't sustain wellness and a sense of remission for the entire 3 weeks, we look at, okay, what have you been doing with your life? And a lot of people are so excited to feel better, they'll just go do crazy things. They'll take on extra projects. And I've tried to tell people that we don't believe in elective stress. You can do elective stress when you're all well, but that's human nature in our group. It doesn't mean they're relapsing, but it could be. And so then it's a matter of time will tell. On my website, I have a list of the most common consternating factors that either derail or preclude therapy. And the first one is babesiosis. Relapsing babesiosis is a game changer and a house wrecker. So I'll just say this quickly. I'll just tell everyone that the two key things that we see outside the clinic aren't being done properly are to use biofilm techniques in an intelligent way, and then to really attack the babesia in a sequential way, and so that it's in remission. In fact, in some of our sicker patients, we're saying, okay, you've been great for 12 months. We want to treat you for babesia again, even though you don't have night sweats or you don't have shortness of breath or air hunger or anything like that. We don't care. I don't care if your organs are still small and appear fit. This is insurance, because now we have your immune system to help us. Because our relapse rate, even as vigorous as we treat, is on the order of 15-20%. We're trying to reduce that by at least half.
Okay, so basically, try to modify it, because you're right, it's human nature when you feel a little bit better that you suddenly go, oh, I can do this, I can do that, I can do and then you take a big crash, don't you? So moderation, I guess you're saying, and take it step by step.
Yep, it's hard to do.
It's really hard to do, yeah. 20 years of trying. Okay, this is a good one. In your opinion, are there any positive changes happening in the way the mainstream medical professionals are handling Lyme disease?
I think so, but not at the upper echelon, not at the decision makers. And those decision makers are bureaucrats. So, I think the bureaucrats who are physicians should be obligated to spend 30% of their time with patients, and so they can continue to learn their craft and not become stale, because they lose contact with reality. The patient-physician relationship is greatly deteriorated for a number of reasons. But I do see, to be positive, I see, and I hear stories of more and more physicians everywhere saying, yeah, I've heard of this Lyme disease. It's nasty. Or yeah, go see this guy. You might have it. I don't know anything about it. I love that when they say that. That's humility. And that means they're open to learning. And we're hearing more of that versus it's a waste of time. It's not a real disease. It's the disease du jour and that sort of thing. And those people that comes from people who probably shouldn't be practicing medicine unless they're surgeons or somebody that cuts things out. But they shouldn't practice medicine with patients with chronic illness, that's for sure.
No, I think you're right. I mean, humility should be the tool of any doctor, as far as I'm concerned. Nobody can know everything, can they? It's a matter of saying, honestly, I don't know, but I'll find somebody who does. Wouldn't that be lovely?
Patient, that's the favorite term that patients like to hear.
Yeah, absolutely.
That's the favorite.
Yeah. This is a more specific one. What, in your opinion, what's your opinion on the use of dapsone as part of a combination therapy? Do you think it improves patient outcomes?
I think it's a useful product, but I think sulfa is better. I use dapsone as a sulfone. It has a minor sulfa side chain. So if you haven't had a class 1 anaphylaxis to Septra or Bactrim or plain sulfa, I'm okay using it, and we do fine with it. I like to pair it with pyrimethamine and leucovorin and a couple of herbs for babesia when patients are in their third cycle, if I can't use sulfa. I talked to Ying Zhang at the Denver conference almost 2 years ago. And unfortunately, he's no longer at Hopkins, but he was such a nice man. We spent 2 hours going over his thoughts, and he wanted to see my programs. So he was taking pictures of my napkins that I was writing my programs on. And He told me flat out, Scepter is better than Dapsone,
Really?
for this disease. Yep.
That's really interesting, isn't it?
Yeah. So I learned from him, or he reinforced what I thought. But I will use Dapsone as a collaborating medication in a cocktail if the patient has a lower level sulfa allergy.
Okay. This is a fairly typical one that obviously we hear over and over again. This person says, I was prescribed a 3-week course of doxycycline, completed that seemingly successfully. Serology was negative. However, joint pains have returned and slowly getting worse. My GP says this is out of his knowledge base, but is happy to prescribe another 3 weeks of doxycycline. What would you advise somebody in that position?
Well, he's got the gentleman, the patient has an embedded infection that's just, it's all about keeping the immune system ahead of the curve, and 3 weeks of doxy in this case is not going to do it. Now, for some people, immunologically, genetically, they may be able to tolerate that and not have any symptoms for quite some time, unless babesiosis is part of the picture. But I think this gentleman's going to fail. I respect the doctor being willing to retreat him, but I think as far as prophylaxis for tick bite, if you have a tick bite and you have systemic symptoms, the most severe of which would be meningitis, you have an embedded infection. You are in it for the long haul. You are going to be chronically ill, and it may be episodic, but in the end, it's going to be a chronic illness.
Okay. Yeah, we do hear that over and over, that scenario over and over. So we've come up to our hour, which has gone ridiculously quick. But there's one question we always like to finish these seminars on. And that question is, what would you say to people who currently have no hope?
And many don't. Choose life over Lyme. If you don't have a realistic access to care, and you've had a history of mixed signals, it's devastating. Write down the good things in your life and write down the bad things, and you'd be surprised sometimes the good things are the longer list. There's just so many people out there. That's why we created the self-help, to try to keep people from that abyss. People don't die of the disease physiologically, they die of hopelessness. Yeah.
Absolutely that. So that's quite a thought to end on, isn't it? But I think with all the seminars that we've done over this year, I think the underlying thing is that doctors like yourself, scientists who we've spoken to, some PhD researchers that we've spoken to, they all give people hope, and sort of listening to people like you speak, that's amazing. So I'd like to say massive thank you for giving up your time. We know it's precious, and the whole team would like to say thank you, and I'm sure everybody listening to you tonight would. We've got some questions in the chat box and a couple of others that came literally just before. So when we've finished at some point, we'll go through the chat box and pick out some questions. And would it be possible we could send them to you when you've got a minute to just flick through?
Of course.
That'd be brilliant.
So,
go on.
Well, I love you guys.
We love you, Dr. J.
There you go. Somebody's put they've unmuted themselves to say we love you. Thanks ever so much.
I think it's important, guys, to acknowledge, sorry to interject, but I think it's important that we acknowledge both of Lyme Disease UK for putting this on, and Dr. J for being really one of the sort of the grandfathers of this industry. Like, if you don't mind me saying, Dr. Joe, I remember you in Under Our Skin, and the industry and the landscape that you're in is not an easy one to be in. So I will submit my question, and but yeah, I just want to say thank you to both of you for for putting this on and supporting all of us.
Yeah, thank you.
Here.
I think everybody would reiterate those thoughts. So I'm going to bring the meeting to a close. Again, thank you so much. Reminder to everybody listening that you will get a copy of the recording. It will appear on our website as well, and you will get a PDF of that really interesting and helpful little brochure that was put together by Dr. Jemsek for the conference in London, with Anne doing a great work putting it all together as well. So thank you, and I'm sure we'll hear from you again soon. Thank you, Dr. Jemsek, and thank you to everybody who's been here this evening.
Thank you.